Today, we're going to be talking about metabolomics, a little bit on nutrigenomics, but in the context of nutritional assessment. So, how do you identify nutritional imbalance in an individual? What are the symptoms of nutritional imbalance or nutritional deficiencies?
This is Nutritional Assessments in Clinical Practice. This is part 2 of a 2-part series. And this week we'll be going heavy into labs and metabolomics and metabolite testing. I am Dr. Greg Nacarelli, as Micah had mentioned. I'm a naturopathic doctor and a PhD in genetics and genomics. And overall, my goal is to ultimately combine natural medicine, integrated medicine, functional medicine with modern day cutting edge techniques such as multiomics, metabolomics, microbiomics, genomics, ultimately with the goal of improving precision and personalization of medicine. This week, we got a lot of great content to get to. We'll be looking at symptoms of deficiency for different macronutrients and micronutrients, and then we'll be going into lab-based nutritional assessments, including different conventional testing, microbiome testing, and metabolite testing. So one thing to consider is that, as is typically recommended, if anyone has done any types of traditional nutrition testing, there's something called the RDA, and this is how much it is recommended to get, or the recommended daily allowance of certain either carbs or proteins or vitamins and minerals. But one thing to know is that the RDA is not listed for lots of other things like phytonutrients or prebiotics or probiotics or functional nutrients. One thing to consider is, okay, how do we assess for these accurately and know that our patients are getting sufficient amounts of these? And so this is where we have to kind of go into other types of testing beyond just looking at traditional metrics such as the RDA. In doing nutritional assessments, we should be aware. What are the symptoms of deficiency for different macronutrients and micronutrients? In general, nutrition deficiencies have been associated with many different things: cancer, thyroid disease, cardiovascular disease, type 2 diabetes, osteoporosis, and just many other health conditions where if we don't have enough of a nutrient, or in some cases too much of a nutrient, we're increasing our risk of disease or poor health. Protein deficiency, if somebody is not getting enough protein, you will see stunted growth, immune system impairments, hair loss, skin issues, skin abnormalities, muscle loss, sugar cravings, edema, and slow healing. With glucose dysregulation, so it's either too high glucose or too low glucose, we're going to see fatigue, thirst, increased hunger, nausea, increased urination, shakiness, irritability, anxiety, and just some traditional symptoms of type 2 diabetes, or even in some cases type 1 diabetes. With fat metabolism, it's a little more insidious, but we should expect to see tiredness, lethargy, metabolic syndrome, memory loss, joint pains, reduced vision, dry skin, lack of appetite, GI distress, and sugar cravings. Fat-soluble vitamins, some of these are characteristic, but then there's a lot of crossover between them. So for vitamin A, when there's deficiencies in that, you have to think eyes. So night blindness is a big one, immune impairment, dry, itchy skin. With vitamin E, it's an antioxidant, so lots of things that are associated with oxidative stress, and then subsequently ataxia, muscle weakness, also impaired vision and immune function. With vitamin D, obviously that impacts our bones, so bone pain, bone weakness, but it also impairs our immune function if we are deficient in it, and increases our risk of fatigue and hair loss. Vitamin K, it's involved in clotting. And so when we are deficient in that, we could expect to see more bruising, bleeding from the nose or gums, or bleeding the GI tract, and also some neurological symptoms as well. But the B vitamins, there's a lot of crossover between deficiencies in B vitamins, but for some of the B vitamins, there's more characteristic symptoms. For B1, lots of different generalized symptoms, but one thing, if somebody is severely deficient in B1, there's something called Burberry. They experience heart, nerve, and brain abnormalities. With B2, always think dermatitis, cracked skin, especially in the corners of the mouth. With B3, some non-specific symptoms, but in severe cases, there's pellagra, which is the 4Ds: dementia, diarrhea, dermatitis, and unfortunately, death. With B5, I always think of it as a adrenal support vitamin. So if B5 is low, think a lot of fatigue symptoms, but also impairments in sleep and depression, irritability. B6, you get similar symptoms if you are in toxicity or versus deficiency. So lots of neurological symptoms, especially ataxia, peripheral neuropathy, and you can experience some swelling of the tongue if deficient in B6. B7, biotin, think hair, skin, and nails if someone is deficient. B9 and B12, very similar symptoms. Both are associated with anemia if deficient, macrocytic anemia specifically. Fatigue, weakness, lightheadedness with B9, and then a B12, a little more neurological if symptoms of deficiency. And then vitamin C, scurvy, think collagen synthesis, bleeding gums, nosebleeds, but then also being fatigued and tired. Low vitamin C associated with immune dysfunction. And then, as I showed last week, those corkscrew hair abnormalities. For minerals, did not cover all minerals, but some major ones. So for iron, also associated with anemia, microcytic anemia, fatigue, lethargy, pale skin, rapid heartbeat, sore, smooth tongue, and then also can affect your hair, skin, and nails. Interesting one, if see somebody craving ice or clay, sometimes you'll even see children eating these. That's associated with iron deficiency. For magnesium, lots of different things. I think magnesium is a cofactor for like 60% of all enzymatic reactions. So it's just a huge player in health and disease states. Numbness, tingling, loss of appetite, cramps, heart arrhythmias. For zinc, skin, immune system, wound healing, slow growth. You'll see all these things impaired. For copper, some similar symptoms to zinc deficiency can also be associated with anemia, weak and brittle bones, loss of balance and coordination. So some neurological symptoms there, in addition to some cardiovascular symptoms. For iodine, it's especially crucial for the thyroid. And so you will see thyroid abnormalities and subsequently symptoms of thyroid abnormalities, such as weight gain, fatigue, sensitivity to cold, dry skin, memory impairments, puffy skin, constipation. And then for selenium deficiency, we'll see an increased risk of infertility, muscle weakness, brain fog, impaired immune function. Selenium deficiency and excess are also associated with prostate cancer risk, so you don't want to be too high, too low. For calcium, especially cramps, tetany, but then also bone issues, tooth decay, cavities, and then also some numbness and tingling. Phosphorus, pretty rare to be deficient unless you have some overt kidney issues. You can experience anemia, loss of appetite, bone pain, deformed bones, and then potassium. I'll see this actually common on just regular traditional labs. You'll see people with very abnormal potassium, either way, high or low, arrhythmia, fatigue, weakness, constipation, low blood pressure, and breathing difficulties. And then very briefly, those are all the deficiency symptoms. For nutrient toxicity, fat-soluble vitamins are the ones people are most common for. Often hear people say, well, how do you know my vitamins aren't messing up my liver? You could check your liver enzymes if you are concerned. You could also check your intake of certain vitamins and minerals. The ones that you should be most concerned with, so actually the most common vitamin toxicity is hypervitaminosis A, so too much vitamin A. In this case, you will see dry, cracked skin, brittle nails, fatigue, loss of appetite, headaches, nausea, vomiting. I've only ever seen this in situations where people are like, they get like gummy multivitamins, but they eat it like they're like gummy bears. So they just eat like a half a bottle and then they eat another half a bottle and then they keep doing it and then they wind up in the ER and it's like, why is my liver failing? It's like, well, it was vitamins, but really it was how you were eating the vitamins. It's not necessarily, if you just took them as prescribed, you wouldn't go into this toxicity syndrome. Vitamin D, I think it's overblown how high you have to go for vitamin D for it to be toxic. Some people say, oh, if you go above 80, you're going to get these symptoms. No, not necessarily. Usually it's above 150 nanograms per mil on a lab test for 25 calciferol that you would be experiencing these toxicity symptoms. Hypercalcemia, nausea, vomiting, frequent urination. B6 toxicity, as I mentioned, peripheral neuropathy, ataxia, heartburn, and then sunlight sensitivity if you're too high with B6. 3. So this is niacin. This is where some people, if you take it at high doses, yes, it could lower cholesterol, but it could also be inflammatory to the liver and then present with some other symptoms, dizziness, low blood pressure, fatigue, headaches. And generally speaking, B1, B2, B9, B12, B7, and then also vitamin E and vitamin K. The toxicity is rare for these, and then for these B vitamins, it's generally considered to be non-toxic, so there's no upper limit for them. So for the RDA, that's how much should you get on general, and then there's the upper tolerable limit, which is how high can you go before you get toxicity symptoms. And so for these B vitamins here, there's not generally a concern. You guys remember all of that, right? No, I know you didn't. So go back in these slides, look at those. It's good to point out. And when you start nailing down certain symptoms of deficiency, you'll be able to see it in your patients. But you have to go over that many different times in order to kind of associate certain vitamin and mineral deficiencies with certain health symptoms. Now, okay, let's say you haven't done all those symptoms checkings, or maybe you're just not as good at it. Labs can help us assess for nutritional status. There's many different types of labs. You can look at the blood, you can look at the hair, you can look at urine, and you could look at stool. There's probably other things that you could test, but these are some of the main ones. One thing to know is that for blood labs, there's serum versus plasma. Serum is essentially plasma minus the clotting factor. So to get serum, you're going to draw it into a tube without an anticoagulant, and then you're going to allow it to coagulate naturally, leaving just this supernatant, which is the serum. And then there's the plasma, which is drawn into a tube with an anticoagulant. And then the blood cells are centrifuged to separate the cells from the plasma, as is seen on the right. There's also white blood cell, red blood cell level testing. This, if you want to check what's going on inside of a cell, you could look at these. Generally, nutrient concentrations outside the cells are higher, not always, But if we see abnormal intracellular concentrations compared to what they should be, there could be other things at play. There could be issues with insulin, or there could be issues with some vitamins or minerals that are needed to get nutrients inside the cell. For white blood cells, essentially all nutrients, you can measure them inside of a white blood cell. For red blood cell, there are some specific nutrients that people like to test. Magnesium, which is actually higher inside red blood cells than it is outside. Zinc, copper, potassium. For B vitamins, often I'll see people running B12 and folate or BC levels. And then you could also look at fatty acid levels inside the red blood cell to compare that to outside of the red blood cell. And it's more of a longer term measurement of fatty acid status rather than just looking at non-red blood cell fatty acids, which if someone just had a bunch of, let's say you took a big omega-3 dose in the days leading prior, they might not have gotten into your red blood cells sooner. So some people like to run both, quite frankly. One thing to know about conventional lab testing, so let's say you're running a CBC or CMP and you're looking at these ranges here, and I can't tell you how many people have run labs, and I asked them, oh, what would your labs look like? And they said, well, my doctor said it's normal. It's like, well, what does normal mean? Because normal is a very wide range, and usually with conventional labs, they're being used to test for the presence or absence of a disease state. And so within that, what about people that are in the gray area? They're not diseased, but they're on the outskirts of normal. So you could look at that as functional ranges. And so they could be functionally low or functionally high. And in general, labs aren't traditionally used for, at least conventional doctors are not using labs to assess for nutritional status, though there are some exceptions for that, such as looking at anemia, where you're looking at iron, B12, or folate. And then vitamin D. Sometimes it's like pulling teeth to try to get some of these, what I consider baseline levels of nutrient status being tested through their doctor, but it is what it is. But anyway, so that's just one thing to consider, especially if you're using another lab to analyze for lab test results. What is the difference between optimal and functional ranges versus pathological ranges? And that could vary between labs. So if we are looking at macronutrients for protein status, things to look out for: total protein, albumin, globulin. You can look at the ratio of these, especially when we're trying to infer immune status. Plasma amino acids, which is generally considered more accurate than urinary amino acids. Carnitine and 3-methylhistidine, which is another marker of protein status. For carbohydrates, fasting blood glucose, HbA1c, insulin. You could look at HOMA-IR, which is a homeostatic model of insulin resistance, which is a calculation of insulin and glucose to figure out, is the person possibly insulin resistant. Triglycerides, fructosamine, which is another marker that could be looking at sugar binding to proteins, such as in advanced glycation end products. Adiponectin, oral glucose tolerance test, where somebody is given glucose, they drink it, and then their glucose is measured over a series of hours to see how quickly their blood spikes and then goes back down. Another thing to consider is if we see alterations in amino acids, specifically branched chain amino acids, and lipids, you can see that with blood glucose dysregulation, especially glutamine and glutamate. You'll see alterations of those with insulin resistance. For fats, lipid profile, of course, cholesterol, LDL, HDL, triglycerides, ApoB, ApoA1, lipid particles, fractionations, and subfractionations to test for fat status, essential fatty acids in the plasma or red blood cells. And from those, you can calculate an omega-3 index, which looks at the amount of percent of omega-3s in the red blood cells. Lipid peroxides, which is typically run in the urine to look at how many of these lipids have been exposed to peroxides. And then oxidized LDL, which is looking at the amount of oxidized fats in an LDL particle. For water-soluble vitamins, generally in the plasma, you can measure these: plasmithionine, thiamine, riboflavin, P5P. For B12, plasma and red blood cell, folate and cobalamin. You could also look at red blood cell parameters. That should be MCV, MCH, and MCHC. For vitamin C, serum ascorbic acid, although know that those levels will go down very quickly. So if you look at it, if you measure someone's serum vitamin C, if they took it, you'll see it spike within 2 hours and it will immediately go back down. So usually I tell people continuous dosing for vitamin C rather than one bolus dosing is best. You could also look at metabolites that can infer these nutritional statuses. So B1, B2, urine alpha keto acids. For B3, you can look at urine lactate and pyruvate. For B6, xanthuronate or kyurinate. You'll see if these are elevated, usually associated with B6 deficiency. For B7, urine alpha and beta hydroxy isovalerate. For folate, Figlu. We need folate in order to metabolize Figlu into glutamate. And so if there is not sufficient folate, you will see Figlu elevated. And same thing with this methylmalonic acid is a metric of our body using B12. High B12 is associated with many pathological disorders. And sometimes I'll see my patients and They'll say, oh, my B12 is good. It's off the charts. And I'm like, no, that's bad. Because why is that off the charts? And sometimes they're not even supplementing with B12. So why is their B12 levels high? Your body should use B12. So one way to look at that is to measure this metabolite, methylmalonic acid. And in general, all B vitamins, if you look at homocysteine and methylation metabolites, which I talked about several talks ago, that's a general marker for if your body has sufficient B vitamins to do the one carbon cycle or the methylation cycle. For vitamin A, beta carotene and retinol. Vitamin D, you could do 125 or you could do 25, which is typically recommended, or the next conversion step is this 125 after the bypass of the kidney. So you could look at those. But generally speaking, most clinics will just run 25-hydroxy D3. You could also look at parathyroid hormone and ionized or free calcium to ascertain vitamin D status. For vitamin E, alpha and gamma tocopherol. And then vitamin K, you're not essentially directly measuring vitamin K, although you could, but really because vitamin K is implicated in clotting, you could measure these clotting markers, prothrombin time and partial thromboplastin time, PTT. And then for minerals, iron, serum iron, transferrin, total iron binding capacity, ferritin, which can be elevated not just if there's low iron, but also if there's inflammation, because the body will sequester iron from bacteria. So you'll see that kind of shoot up. And then you could look at a CBC looking for anemia. Same thing with B12 and B9. Magnesium, serum magnesium, RBC magnesium, and urine magnesium. For zinc, plasma zinc, red blood cell zinc, or serum metallothioneine, which you'll see is altered with low zinc. Copper, serum copper, and the ceruloplasmin, which is a copper transport protein, abnormal in certain diseases like Wilson disease, and then red blood cell copper. For iodine, generally considered not something people test for because it's not reliable. I found if there is one test, it's the 24-hour urine iodine to creatinine ratio, though still that could be atypical. Selenium, serum selenium, red blood cell selenium. You could also look at glutathione peroxidase, of which selenium is a cofactor. So if that's not normal, there could be deficiencies in selenium. Calcium, serum calcium, ionized free calcium, parathyroid, and D3. We could also look at bone resorption markers as a indicator of calcium status. Phosphorus, serum phosphorus, which is typically run on a CMP, and then potassium, serum potassium, or red blood cell potassium. All right, so that's a lot of, again, please go back and read the notes for some of those lab markers, but these are kind of just the fundamental tests when it comes to vitamin, mineral, nutrient status. Hair mineral analysis. First time I saw one of these, I thought, what the hell am I looking at? Because these bars, I feel like it was just not intuitive to understand. So for hair mineral analysis, you use a hair sample. You have to get it at the root, so you have to have that like little skin thing hanging at the bottom of the hair. With this, it's generally considered a measure because our hair takes long to grow of a longer period of exposure, generally 3 months, though the results can vary widely depending on the lab, and it can be affected by many different factors, whether someone had previous hair treatments, their growth rate. And it's not necessarily indicative of levels in the body. Sometimes I'll see something might show up in a hair mineral analysis, but it's different on the blood and urine. So, it's not something I generally use for testing. Some people really like it. There are some things it is well validated for, like drug analysis, Fragile X diagnosis, and alopecia. At best, I would say combine it with other types of lab testing, though I wouldn't use it solely to assess for nutrient status. Urine analysis. And so, this can identify nutrient imbalances, especially if you're looking at organic acids. So like I mentioned, kyurenic acid, xanthorenic acid, if elevated, associated with B6 deficiency, alpha keto acid associated with B1, B2 levels, and alpha and beta hydroxyisovalerate associated with B7 levels. You can look at urinary amino acids, though I find looking at plasma is a better indicator of amino acid status than looking at what your body is getting rid of. Via the urine analysis. The 24-hour urine iodine might be useful with the creatinine ratio. Some people do toxin testing through urine and mycotoxin testing, heavy metal testing. There's the controversy with provocation. And so usually if I am testing heavy metals, usually it's because on a blood test, I've seen somebody was elevated, and then I recommend something called a provocation with urine. And so you use a chelating agent to tell your body to start getting rid of the heavy metals. And I've seen pre and post provocations where if they just test for heavy metals in a urine sample without the provocation, it's like little small amounts of whatever, mercury or lead or whatever. And then they do the provocation and it's like 30 times higher. Not exaggerating.
Are chelating agents the only way to do that, or are there other methods of provocation that work?
Yeah, so I would say, okay, this is my own clinical pearl. I can't say this has been tested, but so with the provocating agents, like for example, DMSA, EDTA, these usually have a very strong sulfur group that is charged to pull the metals out of tissues. There are other natural agents that can do this, like NAC and glutathione. And so what I usually recommend is if somebody is exercising a lot, they're sweating a lot, and they're taking supplements that will help to pull these metals, whether it's chlorella or NAC or cilantro has actually been shown, horsetail, which has a lot of silica in it. I've seen people do that and also kind of provocate. It's not as strong as an IV provocation. IV provocation is very strong, or even an oral provocation, but I have done that with people. What I don't like happening is when I suspect heavy metal toxicity and someone does a urine test and it comes back low. And they're like, "Oof, thank God I don't have heavy metals." And I'm like, listen, everyone has heavy metals. Some people have more than others. It just depends on where you live. I've had so many of my patients from California have high blood lead levels. And I don't know why. So, usually I'm being very, like, if I suspect a true heavy metal toxicity, and this is actually like, you look at the Mayo Clinic or CDC, they actually do recommend a chelating or doing a test with a provocating agent, because they know you're not going to get proper results. But yes, I do use natural agents for that.
Nita mentioned ALA. Do you ever use that?
Absolutely. Yep. ALA is another great one. Anything with a strong sulfur group. Taurine is another one. Now, some people get sulfur sensitive, and that's a whole other conversation. But generally speaking, if they're not sensitive, yeah, that's a good one. Okay, so yeah, with some nutrients, you want to use urinary creatinine as a ratio to normalize levels, though the issue with that is that if your creatinine levels are off, then it could skew your results. So for example, if you have a diet very high in protein, you're doing vigorous exercise, you have high muscle mass, or you have kidney issues or dehydrated, it could make your levels on a urine test look abnormal. So that's another issue with urine testing. I found this interesting study. They were looking at the timing of metabolite testing in urine. And regardless of the metabolites, they had a couple individuals here. And as you could see, there's certain trends that are observed when you're measuring urine metabolites. And these are the same metabolites. You'll see this kind of indicative shift in the morning, this kind of peak in the afternoon, and this divergence in the evening. And so depending on the time of day, it's highly variable, the urine metabolites. So it's just another factor to consider. When is somebody testing their urine metabolites? So this type of thing matters. There is dry blood spot testing. So for this, a small amount of blood is collected onto a card. It's a high purity cotton liner. So with a finger prick, do a couple blood spots. This is a minimally invasive alternative to venipuncture. The nice thing about this is it does not require special treatment storage. It's generally stable at room temperature for 15 days or longer. Typically had been used for newborn screenings, especially for inborn errors of metabolism, but is expanded to at-home testing for various different methodologies, such as metabolite analysis. And you could look. So there has been validation studies that have compared dry blood spot testing to whole blood versus plasma testing. As you can see, here's a dry blood spot analysis comparing that to venipuncture whole blood A1C. This is a trend line. When you see R squared, it's essentially like 1 is exactly a perfect association. Anything above 50 is generally pretty good. For this, you see a R squared valued of 0.92. So a lot of agreements here for the A1C. They looked at plasma glucose. Again, pretty good association there. Dry blood spot for CRP. Again, generally trends very much. For serum HDL, even the test within HDL itself was kind of all over the place, but generally speaking, there's a large agreement there. And then something like cholesterol as well, generally a indicative trend line. Let's talk about the microbiome for a little bit. Looking into the microbiome is one way to assess for nutritional status, and it could differentiate between a suboptimal diet or a foundational diet. And so a not good diet is going to have certain changes on our microbiome, and we will be able to observe this in changes in the microbiome itself and metabolites not only in our microbiome, but in our blood as well. And this is going to lead to adverse health states compared to a diverse microbiome is going to create a more diverse array of metabolic byproducts and affect nutrient absorption. And this is going to promote optimal health and wellness. The really cool thing about this, I love the microbiome because I feel like it's the connector between conventional medicine and integrated medicine in terms of the impacts of it. If all disease starts in the gut, that's a very ancient quote from Hippocrates, but it's true. And so we talk about vitamins and minerals. These are not just things we have to get from our diet. We can make them ourselves if we have the right microbes. And we are at a point in science where we have identified what microbes make these things. And so, for example, certain yeast products can make vitamin D. Vitamin E, lots of different microorganisms have been shown to make this. Vitamin K, I know you've probably seen these in some of your probiotic supplements if you've taken them. Bacillus subtilis, Lactobacterium. B vitamins, there's a lot of microorganisms that have been associated with B vitamin metabolism. And actually, my next slide here, you could even isolate it down to the individual B vitamins. So B1, Bacteroides fragilis, Lactobacillus casei, for B5, Prevotella, Quiperi, Helicobacter pylori. We thought this was just a bad thing, right? Helicobacter is actually a resident microbe. It's not just something. I have a H. pylori infection. You can overgrow H. pylori. That's another thing. But a lot of people, healthy people, have H. pylori, and it makes some nutrients for us, like B5. Tetrahydrofolate, lots of different organisms here. So this is what happens when somebody takes antibiotics and they wipe all these out. You're not just, this is why there's health consequences, is that you've now impacted your microbiome from making good things, not just vitamins. There's lots of other nutrients and cofactors that I may not get to today, but they are implicated in health and disease states.
Also, I did drop in the chat where you guys can preview our microbiome test. And something that isn't mentioned in the video I put in the chat is that it will have a antibiotic resistance marker in there.
Awesome. Neurotransmitters as well. So, other than vitamins and minerals, one thing that, again, is probably one of the coolest, I'll put it in the top 5 coolest things I've learned in the last 10 years, is our vagus nerve, which goes down and innervates our entire digestive tract. It goes both ways. It's not that our brain just sends signals to our gut. There are signals that go from the gut up to our brain. So when you get that visceral sensation in your gut, when you're sensing something, it's a signal from your gut to your brain. What is actually being transported? Well, amongst many things, neurotransmitters. So for example, Lactobacillus plantarum, specifically this strain, makes GABA. We have, let's see here, Enterococcus faecium also makes GABA. We have Proteus vulgaris, Bacillus subtilis. These are like spore-based probiotics, make dopamine, norepinephrine. Our bifido species are so important, and they will make serotonin and tryptophan. So this is a lot of thing. You go on antibiotics, you might wipe out your neurotransmitter production to an extent. This is where they say, like 90% of serotonin is in the gut. It's being made in the gut from bacteria, and it makes its way up to our brain. That's why with a lot of neurological disorders like Parkinson's and Alzheimer's, the first symptoms you see people have are constipation and issues in their gut, because that's what's changing first and foremost before you even see the pathological changes of forgetfulness and ataxia. So those were just from, we talked about B vitamins and neurotransmitters. There's other metabolites that we could measure that we can measure in our blood. And so, for example, short-chain fatty acids, tryptophan catabolites, especially when you're looking at our microbiome's impact on our metabolome, you have to look at tryptophan metabolites. So that's another thing. TMAO, which is generally considered not that good. Secondary bile acids, branched chain amino acids, lots of different associations with that in health and disease states. Polyamines like spermidine associated with aging, and then obviously bacterial vitamins, like I just mentioned. So one thing that people need to understand when we're talking about vitamins and minerals, these things act as cofactors and prosthetic groups for enzymatic reactions. And so, for example, niacin acts in redox reactions. Folate is involved in methylation. Pantothenic acid is involved in oxidation reactions, and then as prosthetic groups involved in decarboxylation, like for pyruvate decarboxylase. That's why they say take B1 to help with carbohydrate metabolism. It's because it's helping you break down the glucose into pyruvate to enter into the TCA cycle. So that's how these vitamins and minerals are helping us through these metabolic pathways. So that's one thing to remember. That's why they're important, is they're impacting our metabolism and helping our body function. If you're looking at comparing our nutrigenomics to our metabolomics, and again, nutrigenomics, as I mentioned last week, is looking at our genetic predispositions regarding nutrient metabolism. And so by understanding nutrigenomics, we could see how our genetic predispositions toward altered metabolomic pathways can be affecting our health and disease states. When we look at our metabolomics, we're looking at the impact of nutritional status on our metabolic pathways. And so essentially it's considered.
Can I interject here? I actually have a screen share I was working on right before this. It's not done. It's really rough, but would you mind if I brought that
Yeah,
up?
no, absolutely.
I'm more of a layperson, right? So I like to create things that are very simple representations of complex ideas. And this was just for my own thoughts. So you guys are looking at a very rough draft of some visuals that I'm starting to create. But essentially, when we're looking at genetics, it has the potentials of who you could be locked into genetics. So this is Oprah Winfrey. You could take Usain Bolt as an example, or whoever you want. But but within the genetic makeup of Usain Bolt or Oprah Winfrey, there are many different versions of that person that are a possibility. So you could have fastest man in the world, Usain Bolt, or you could have overweight, washed up Usain Bolt within your genetic disposition. However, what metabolomics is looking at is the actual state. So is this the fastest man alive, or is this the washed up, overweight version of this person? And so by looking at the actual state of the person, that then tells you the inputs you need to make to become a different person or a different state of your genetic potential.
That's absolutely an excellent point. Yeah. I mean, that's why I think people, if they get hung up on just looking at their genetics, and I think the impact of genetics on things is a little bit overstated, we need to also consider our the other factors that are impacting that. And that's where the nutritional status comes into play. I think one of the most wrong things that genetics has done is make people, or just the concept of genetic determinism. Like, because I have this gene, then I am this way. And it's like, no, usually
It's almost unlimited within genetics.
Yeah, for the overwhelming amount of people, genetics is not going to be deterministic of their health. There's going to be other factors to consider. So combining nutrient testing with metabolomics. Metabolomics serves as the connector between nutritional sufficiency and health. What I have on this right hand side here is just our metabolic pathways. There's a lot going on here, but this is where the vitamins and minerals are serving as cofactors and prosthetic groups within all these different enzymatic pathways and metabolite pathways. And so if nutritional needs are being met, you should have optimal metabolite pathway functioning. If nutritional needs are not being met, your metabolic pathways will not be functioning optimally, and this is where you will experience dysfunctional metabolite pathways and subsequently alterations in health and disease risks. There have been 25,000 metabolites that have been identified in food. So there's a lot going on there. Half of those metabolites have some interaction with the gut microbiome, and so there's this interplay between from food, from the gut microbiome, and then from ourselves. There's lots of different metabolites that are kind of in flux. And so we can measure this. So scientists have looked at from different diets, foods, and then when health and disease states, what metabolites are associated with these. And so, for example, we could look at certain different diets. And so, for example, the DASH diet, which is typically recommended for people with high blood pressure, rich in fruits and vegetables, moderate in meat and poultry, you could see different metabolite profiles, right? Some of these we could identify, ornithine is amino acid, S-allele, cysteine. For people that have done supplements, you might recognize this one. I'll let the chat try to figure it out. It's in a certain, let's say it's in a certain food item that makes your breath stink. But anyway, we could measure that in this certain type of diet. For a Nordic diet, rich in berries, fish, fruits, low non-fat dairy, we could see certain types of nutrient profiles as well. Lots of some tryptophan metabolites being recognized here. The indole amino acids like phenylalanine. For unhealthy diets, let's say we have desserts, fruit juices, potatoes, refined grains, sugars. We'll see some not good stuff, right? So bradykinin is typically a compound that's associated with, well, it's one of those compounds that accumulates if people are on ACE inhibitor medications, which makes them cough. But it can also be associated with these not so good diets. We have this other one of these over here. I think it's this one of these is a trans fat. But either way, you'll see metabolites that are just associated with poor health and disease states. Mediterranean diet, you'll see, and the more vegetables and fruits you add to a diet, you're going to start seeing metabolites that are associated with just coming from these fruits and vegetables that are measurable in our blood. Mitochondrial metabolites as well, succinic acid, phosphatidylcholine. Ultra-processed foods, this was one I was thinking about, oleic acid. This is actually a trans fat. There's that bradykinin again. Saccharin, which is interesting because that's artificial sweetener, but I guess it's found in these artificial foods as well. A vegan diet, lots of different metabolites that are just coming directly from the foods as well, like beta-cryptoxanthin, indole 3-propionic acid from cruciferous vegetables. Healthy plant-based diet, again, you'll see a lot of these plant-based metabolites. You could also look at it from individual foods itself. So for almonds, people say you get vitamin E from almonds. You could actually measure it. Alpha tocopherol. For beer, some cysteine, some D-lactose. Bell peppers, you get the capsaicin. Butter, undecylenic acid, which is antifungal. Cheese, you'll see some individual things. Coffee, you see some polyphenols as well as some other compounds as well. So you could see this from different foods. You can measure the metabolites that are being derived from the food products themselves, and some of which are associated with health and disease states. So you could also look at the metabolome for specific diseases. So for example, for cardiovascular disease, you'll see shifts in alanine, aspartate, glutamate metabolism, glycerol phospholipid metabolism, phenylalanine metabolism, citric acid cycle shifts. And so you could look at those. Another one is tryptophan metabolites. So for cardiovascular disease, generally speaking, you'll see alterations in the chyrenic acid pathway. Additionally, the chyrenic acid to tryptophan ratio. Again, if tryptophan doesn't go down this serotonin and subsequently melatonin pathway, it'll go down this other pathway where chyrenic acid is formed. So that kind of makes sense. So you could look at these individual metabolites. Same thing with serotonin as well. You see alterations in that with cardiovascular disease. For inflammation, you can see changes that are associated with metabolites that are elevated in inflammation and metabolites that are decreased. So for example, with inflammation, you're going to see decreased some amino acids here, decreased lysine, decreased valine, trimethylamine oxide will be increased. And then subsequently, for anti-inflammatory benefits, generally speaking, lower tryptophan, butyrate, lower methionine, propionate, associated with inflammatory states. So you could look at these metabolites just to see, okay, does the person have more anti-inflammatory metabolites or inflammatory metabolites? Aging, so within aging, there's different things to consider. You could look at cognition. You could look at just general markers of aging, markers fasting or frailty markers. And so you could associate, okay, is this individual have a predisposition towards frailty? By looking at these individual metabolites, like some amino acids, methionine, proline, and then some gut-associated metabolites like 2-keto-butyrate or urate, branched-chain amino acids. Again, generally speaking, they're associated with not good things. So what are alterations in that are also associated with aging states? So you could assess that as well for aging. Mitochondria is probably the most common associated metabolites that people will look at for health and disease states. And so for mitochondrial health, essentially you're looking at the TCA cycle, citrate, isocitrate, alpha-ketoglutarate, etc. You'll see it's not so much that like uniformly low or uniformly high is associated with a health or disease state. It could kind of fluctuate. Generally speaking, if I see one metabolite is very high and then another one is very low, it indicates some type of block somewhere in this pathway. So that's generally speaking what I'm looking for in order to associate this with many different health and disease states. Fasting as well. And so if somebody is fasting, you'll see shifts in their metabolome. This is why, generally speaking, when the timing of testing, whether it's urine or blood, you want to make sure that the timing is correct. And so you'll see changes in butyric acid, organic acids, azocarnitines, branched-chain amino acids, a shift towards gluconeogenesis the longer you're fasting, and some other alterations as well. Purines and pyrimidines, like spermidine as well is another one that will shift. Brain health as well. So especially metabolites that are detrimental to brain health. This is something we could also measure. Some of these metabolites are associated with Alzheimer's, anxiety, autism as well. This 4-EPS and 4-cresol especially is not good metabolite. It's a tryptophan breakdown product. Trimethylamine oxide, short-chain fatty acids, phenolic derivatives, TUDCA, which is something people could supplement with. This is actually a beneficial metabolite that you want elevated. So there's all sorts of metabolites we can look at for various different health and disease states. And one of my favorites is looking at it for toxin status. So something like PFAS exposure, which is perfluoroalkyl substances. This is part of those forever chemicals that people are exposed to. If people are exposed to toxins, we will see shifts in the microbiome. So this study was actually done in a cohort of younger people. And so, and this was looking at several different cohorts, and you see this trend towards abnormal tyrosine metabolism in PFAS exposure, alterations in glutathione metabolism, alterations in arginine, proline metabolism, fatty acid biosynthesis changes. And so you could essentially look at the metabolome to see that there has been a shift in response to exposure to certain different toxins and chemicals. All right, so in summary, for metabolite assessments, consider assessing metabolites to elucidate the effects of nutrient status on metabolic pathways. This can be used for disease risk assessment, health optimization, toxin exposure. Blood metabolites are more stable and indicative of health indices than urine, and we can track changes in metabolites to assess responses to interventions. And overall, nutritional assessment summary. So we want to look for symptoms of nutritional deficiencies or toxicities. We can do this by analyzing a patient's diet for nutritional sufficiency. And one of the best ways I think one could do this is by using a tracking app. We'd also look for nutritional inadequacies on conventional lab testing, such as looking for anemia on a CBC or abnormal electrolytes on the CMP, etc. We could look at the gut microbiome and looking for the impacts of nutritional metabolism on that. Secondarily, we could also look at urine and hair, secondarily to blood analysis for inferring nutritional status, and ultimately to evaluate our metabolite pathways. It gives us a better understanding of the impacts of nutritional status on our health and disease risk. And so with that, thank you for attending. If you want to speak with me one-on-one, so I work for Therium. We offer a metabolomics test. And so if anyone is interested in speaking with me regarding that, you can sign up with this link. And
yeah, I would add to that. Obviously, Greg is an expert in many of these areas to do with lab testing, nutritional assessment, et cetera. But, it expands far beyond what was just discussed today. If you are a medical provider and you are interested in looking deeper into metabolomics and how that could potentially aid your clinical practice, then I highly recommend talking with Greg one-on-one, because he'll be able to kind of curate the information based on what you're interested in, what your patient base looks like, etc.
And otherwise, I will open it up for question and answer. So thank you so much for attending.